Let's begin the first part of heart disease with valvular disease. What a fun topic. I know you're going to love it. I just do. I know you. You're special. Every one of you. All right. Well, I hope you enjoyed that. I appreciate you. Okay, so we're going to start out talking about faulty pump construction. So genetic types of abnormalities, so congenital, man, I'm having a hard time with speech right now. I can't do two things at once, as you just saw. So con refers to the same thing, con means in Spanish, which is with, and genital literally refers to the genitals with regards to procreation. So congenital means that there was no error that's hopefully detectable genetic-wise, otherwise it would be a genetic abnormality. Congenital means that DNA conformation happened appropriately, but there was some sort of error in utero. So congenital is referring to a developmental, generally in utero, damage. So we'll talk about that. I have a lot of handouts for those of you who are taking this in person that will really help you to understand these. Another thing that's important is to go over your general anatomy and physiology of the cardiovascular system, especially the fetal bypass channels. And if you understand the fetal bypass channels, that will help you understand this. The other thing that we'll go through in this short video, I promise it's short, crazy, right? Faulty valves. So we call that valvular heart disease. So there can be some abnormalities with the valves. Either they're too tight or they're too leaky. So that's called stenosis or regurgitation. Regardless of which of those occurs, you're going to see that the heart has to pump the same blood twice. So either there's backflow from the system and then the ventricles are going to have to pump twice in the case of a too leaky valve, or there is a leaky AV valve. So again, the ventricles or the atria in some cases have to pump twice. So we'll take a little look at that. And then in other chapters, we'll go through coronary heart disease and hypertension, and this also is going to tie into primary myocardial disease, which is a very common type of heart failure and very common in the area where I am currently, which is Buffalo, New York. All right, so congenital heart disease. Congenital heart disease can fall into two separate categories. So I'm going to write them down to the best of my ability with my little pencil guy up here. So they can either be cyanotic. I've found that it's easier to write in cursive with this. So cyanotic or acyanotic, meaning without cyanosis. Cyanotic. Yeah, that looks great. Okay, so cyanotic means that there is going to be a lack of oxygenated blood as a result of the abnormality, whereas an acyanotic abnormality would not cause those things and might just be detectable through other types of difficulties with exercise tolerance or something of that nature. So there's a couple of different things that are associated with damage congenitally to the heart valves. German measles, Down syndrome, certain drugs, we call them, here right on the bottom, teratogenic drugs. Drugs can be graded as safe through pregnancy everywhere from A to X. The medications that cause a lot of the fetal damage aren't necessarily drugs that are illegal. One of the classes that causes most damage, or the highest amount of damage in relation to other medications, are anti-seizure medications. So it's important when you're thinking about drugs people are taking, or if you're recommending drugs to people who are pregnant, to look at their pregnancy grade and then make appropriate choices, because we want to minimize fetal harm, but then also do a cost-benefit ratio to the mother. So with regards to seizures, for example, seizure activity is increased typically in people with epilepsy during pregnancy. However, remember that the organs are being created just during the first trimester. So everything is being conformed in the first 12, 13 weeks. After the first trimester, everything's just getting bigger. So if you can avoid medication use, at least during the first trimester would be most advantageous. So what you're looking at here, this is a normal opening. It's called the foramen ovale. And the foramen ovale is an open communication that exists in utero that allows the exchange of blood from the right to left atria. Because you might know, hopefully, that babies or fetuses, embryos, they're not utilizing their lungs yet, right? They're not breathing, they're underwater in uterine fluid. So what they have is a placenta that then attaches, draw one, here's a baby, there we go. That looks just like a baby. And the umbilical cord attaches to the umbilicus, which is the technical term for belly button. And this is a placenta. They are big, they are huge. And the placenta is embedded as part of the uterine wall. You can't move it, it grows in there. It's part of the wall. And on the other side of the fetal blood vessels are the maternal blood vessels. So the nutrients and oxygen from the mother they don't directly connect to the fetal vessels. That's called a transfusion syndrome. That's incompatible with life. So they are as close together as you can get so that there's just diffusion of contents. And then things like oxygen, they're given through the umbilical region, through the umbilical cord. So the lungs aren't active at this point. So why would we have to have blood going from the right side to the lungs, coming back to the left side, and then going out? Instead, this is open. It's called a fetal bypass channel. We've bypassed the lungs. And when something is open in medicine, we call it patent, right? Oh, it's already written down here. Patent. So the patent foramen ovale, or foramen ovale, would be the failure of this naturally occurring fetal bypass channel to close. There is a second one up near the pulmonary vessels up here. It's not labeled in this picture, but it's called the patent ductus arteriosus. And same thing, it's going to allow an open communication and bypass these pulmonary vessels so that we don't have to have this exchange. Instead, we can just mix blood with the atria and ventricles. So that's the first type of congenital abnormality. It's just a failure of these normally occurring fetal bypass channels to close. So after this fetus is born and becomes an infant then, so let's pretend that this uterine wall isn't there, but they have their placenta, and there is a cord that's clamped, and that causes requisite pressure changes to occur within the vascular system. And that will, if everything goes correctly, cause the flaps between the atria and then the openings in the ductus arteriosus to close. And then it becomes a closed circulatory system and the lungs become active. What you see with, we call those ASDs, atrial septal defect, because the patent or the foramen ovale is quite large, unfortunately, when these are open, a large amount of them do require surgical intervention. So why I say that is technically the most common type of defect, congenital, is a VSD, a ventricular septal defect, a VSD. And the good thing about a VSD is that most of them are very small. And these are muscle cells, which we know get larger. So this can be monitored when it's something that's noticed, and a smaller amount of open VSDs, which wouldn't be naturally occurring, it would just be an abnormality with the development of the septum, don't require surgical intervention. Okay, one other thing that I want you to remember and think about logically, which is why I want you to draw to the best of your ability, is thinking about right to left shunts or left to right shunts. So when there's open channels, it can either be right to left or it can be left to right. So let's start with right to left. In a right to left shunt, you have deoxygenated, so I'm going to change my color down here to blue because I want you to visualize this. So if we have a right to left shunt, we have deoxygenated blood from the right side mixing with the left side. And remember, the left side is going to just convey that blood up to the body. Well, here's the aorta way up here. So that is going to be something that's going to cause mixing of deoxygenated and oxygenated blood. So same thing with the atria. If it's a right to left shunt, we have deoxygenated blood from the right side entering the left side of the heart, which will then convey it to the system. Okay, so now let me go back to red. Are you ready? I can't talk and choose things at the same time. So if we have a left to right shunt, so the left side is filled with oxygenated blood, right? Yes, it is, Dr. B. It is. Oh, good job, guys. I'm very proud of you for knowing that. So in that case, you would have oxygenated blood from the left side entering the right side, and the right side would send it back up to the lungs, and then it'll come back, and you'll have extra oxygenation. Okay, so that's going to cause a lot different effects. So same thing if it's up here. If it's an opening communication between the atria. If it's a left to right shunt, same thing. We're just at a different point. We'd have oxygenated blood coming in here, and then it would go through that process, go to the lungs, and then we would have super oxygenation, which is probably not a huge deal, probably. Okay, but when you see these right to left shunts, you're going to have the mixing of oxygenated and deoxygenated blood leaving the system. That can cause cyanotic effects. So I want you to keep that in mind. Right to left shunts, we'll see some cyanosis. The body is pretty good about supplying oxygenated blood to the places that need it the most to keep you alive, which means typically what you see starved are the most distal portions of the body. So this is a case of clubbing of the fingers. We've mentioned probably VEGF in every class so far, so we're going to say it again. When tissue is ischemic, it releases a signal that VEGF needs to be created, which is a growth factor, and that will cause more differentiation of blood vessels. That also is going to increase size, which we see with tumors as well. So in finger clubbing, this is a pretty extreme case of finger clubbing, that lets you know there is a cyanotic problem starving the distal appendages of oxygen, and then compensatory changes leading to an increase in size. We can do this test ourselves if you want to play along at home. So if this is a thumbnail, so here's a thumb looking this way, and this would be your nail. And if this is another thumbnail, that looks really good. Yeah, looks great. So when you put your thumbnails together, there should be this little window between the base of the nails that you could see light through. When that exists, that tells you that there's no finger clubbing and there's no ischemia in these tissues. When you look at cases of COPD, for example, you'll see that those spaces, they start to flatten out, and maybe there's not a window you can see through. So you'll see these finger clubbing mechanisms and associated VEGF alterations with any kind of ischemia in the distal appendages. Okay, so that was my little overview of right to left, left to right shunts. All right, so we can have atrial septal defects, or an ASD. The most common are VSDs, ventricular septal defects. There's also combined, so there would be an open atrial and an open ventricular septal defect. So these can be monitored in pregnancy. These can be seen at birth in some cases. So there are ways to address this. Depending on where the location is, the surgery can be done immediately, or it's something that has to wait a little bit depending on the tissue that needs to be corrected. Okay, then there's also abnormalities obstructing flow. So there can be pulmonary stenosis. So perhaps the pulmonary arteries or pulmonary veins are stenotic, so they're not allowing good blood flow in or out. You can have stenosis of the aorta, so that becomes smaller and it's harder to get blood out. Then there's something called coarctation of the aorta, which is stenosis, but also you end up with an abnormal location of the aorta. And sometimes we'll talk about another term that is called an overriding aorta. And in diseases like tetralogy of Fallot, there is an open septal defect, there's pulmonary stenosis, and there's also an overriding aorta. So instead of the aorta coming and attaching to the left side of the heart, it's right over the kind of connection of the atria, which means that deoxygenated, partially oxygenated blood is going to mix and go right up to the aorta. Okay, so coarctation, so those are flow abnormalities. There's also abnormal kind of connections. Transposition of the great vessels is a malpositioning of vessels. Again, you'll see this on your handout in a little bit. And then tetralogy of Fallot, as I've mentioned, that combines combined septal defects, pulmonary stenosis with an overriding aorta. So when you think about these types of abnormalities, I want you to think about which ones would be cyanotic, which would be acyanotic, if that means a right to left shunt. If it's a patent like ductus arteriosus right up there, there's not a lot of symptomology with that, but because of the location and the branching off of the aorta, you can actually see differences in oxygen levels, like O2, between the left and right hand, for example, or arm. Okay, one other thing that I want to go over just very quickly, and I'll mention this again, when there is a turbulent flow, like swirling abnormal blood flow in a region, it has a name and a sound associated with it. When it's associated with a valve, like a heart valve, we call that a murmur. That's different than if it's in a different part of the body. It's referred to as a bruit, and we'll talk about that later. That's a French word. I'm not French, and I don't say it very nicely, but a bruit refers to the sound of blood rushing over an obstruction. A murmur is turbulent flow, same thing, but it's in the heart, in a heart valve. So that's what it means by heart murmur. Okay, so there's a whole bunch of congenital heart diseases. The best that individuals can do is prevent intrauterine injury, taking note of the pregnancy safety levels of various prescribed medications, but sometimes these things just do happen idiopathically, meaning that there's no direct detectable cause. So monitoring and treating surgically if necessary, and lifestyle modifications to increase oxygen flow. Okay, so now we're just into valves. There are a bunch of different valves that we've mentioned. There's the semilunar, so we have aortic semilunar and pulmonary semilunar. Then we have the AV valves that connect the atria to the ventricles, so those include the mitral or bicuspid or the tricuspid. So there's different things that you're going to see, and when you look at pictures like this, if you've been practicing, what you'll see is that you'll start to see some connections between things. Like this is a fibrotic type of change. So this is a congenital abnormality with early scarring. And this is nice young tissue. This is really native fibrotic tissue. So we can see by looking at this with practice that this is more of a congenital issue. Whereas this is a type of disease you would see. These are some lesions that you'll see with very specific types of infections. So this is more likely to be associated with a bacterial type of infection. We'll see that in a little bit. We're also going to have the specific lesions associated with an infection. And when these infections happen, like you see this with untreated strep throat, for example, when the staph bacteria end up in that area, we have some damage to the tissue. So as you can see, this tissue starts to die. And when organ tissue is damaged, it releases something called tissue factor, which starts the coagulation cascade. And the whole part of the coagulation cascade, the whole point of it is to develop fibrin, which makes up scar tissue. So you see this overactivation of fibrin, and then you get scarring. So here we have cusp fusion. So scar tissue has fused some of these cusps together so that now we only have this little bit of availability for blood flow. In this final picture, so there's a lot of redness and inflammation. So we can see this is a more chronic type of damage. The other thing that you see here is calcification. So this is very severe calcific aortic stenosis. So this is an aortic valve, the semilunar, and this is the area that is available for blood flow, which means the afterload rate is very high. So the heart has to contract at a very high pressure to force blood through here. But the other thing about calcification is that it takes a long time to build that up. So we'll see more chronic injuries leading to calcification with more acute injuries not exhibiting this calcification. One thing that you can see, you can image calcification, so it does appear, and even things like an X-ray in some cases. Okay, so two different types of valvular dysfunction. Again, we can have a really leaky valve, or we can have a really tight valve. So they are called either regurgitation, which is too leaky. So if you've ever regurgitated, that means you've burped up a little bit of your food, meaning your lower esophageal sphincter was too leaky. It didn't close completely. So now that food is refluxing up, and then it can get to your mouth. That's regurgitation. So too leaky, vessel or valves can do that too. If the leaflets don't close together appropriately, they can prolapse in some cases, and then the blood backflows. Whereas stenosis means there's osis is development of, and stena is referring to a tightening or a hardening in some cases. So stenosis, so a development of a narrowing of a valve. What you see is that the AV valves, most typically the mitral valve, because it's on the left side, is the most commonly damaged AV valve. Most of the damage seems to be to AV valves, and it's usually the mitral. When you see that the tricuspid is damaged, in 50% of cases, that has to do with somebody injecting into the venous system, and then that substance then comes up to the right side of the heart. And if there's any binders in that drug, if there's anything abnormal, you can get damage then to that tricuspid valve. What you're going to see more typically is mitral valve damage. That's the side that has to work harder, and that's the most typical valve that's damaged. And it doesn't matter which one you have or you see in a patient. Both stenosis and regurgitation increase the work of the heart. They increase the volume of blood and pressures in the chamber, because either the heart is going to have to work really hard to move blood on, which means you're altering your stroke volume and end systolic volume. The pressures are going to go up, and as a compensatory mechanism, you'll see that the chambers dilate and become hypertrophic. Eventually, if these are not fixed, and really the ways to help fix them besides lower the heart rate, lower the workload of the heart, are things like artificial heart valves. If those things are not done, the heart fails from something called high output heart failure, which means it beats too hard for too long. So it is a serious disorder, and some of these can be really easily prevented by taking an antibiotic when strep throat is found. So we take them seriously because we can get really severe damage from it. And just so you know, a heart valve doesn't last forever. They're typically replaced every 10 to 15 years. And also, if they're made of metal, for example, they do damage red blood cells as they flow through, which means they're destroyed more quickly, leading to symptoms of anemia and then overwork of the marrow. Okay, the first disorder we'll talk about is mitral regurgitation. The mitral valve is the AV valve that separates the atria from the ventricles, right? Yes. That is what it is. We'll look at mitral valve prolapse really quickly, but any kind of inflammatory or untreated bacterial infection, so that's called rheumatic heart disease. That mainly has to do with strep type bacteria. Infective endocarditis could be another type of bacteria. Different connective tissue disorders like Marfan syndrome, there are abnormalities and too much stretchiness sometimes of the connective tissues, and just general cardiomyopathy means cardiac muscle disease. So lots of things can cause regurgitation of the mitral valve. And if we think about, again, just where the mitral valve is, it is connecting the atria to the ventricles. So the important part, though, is that when the mitral valve is supposed to close is when the ventricles contract. If that doesn't happen, the blood will then go back up to where it came from. And in that case, it's going to be these pulmonary vessels. So this is going to cause blood to flow simultaneously up through the aorta. It can go back to the atria, or it can back up to the pulmonary system where it came from. But basically, you're going to see changes to the left side of the heart. So we're going to have this continuous backflow. Instead of just getting the flow out through the aorta, some of it's going to send blood back to the atria, which is supposed to be where the blood doesn't go again. We want it to go atria, ventricles on, not atria, ventricle, on. Instead, you'll see that this ventricle now has to beat twice to move the same amount of blood. So both the left ventricle and the left atria are going to have to work harder. So the whole left side is going to become bigger. So the left ventricle becomes hypertrophic. We see the left atrium becoming hypertrophic. As I said, that's going to back up to the lungs. So the pressure in the lungs is going to go up. And then the pressures from the lungs are going to affect the right heart, and then both sides of the heart work together. So if the left heart is overworking, and then the lungs are building up with pressure, then the right heart's going to start to fail because it's connected to the lungs. So if this is not corrected, this does lead to right heart failure. And because the right heart starts to fail, that's when you see venous backup. That's when you see the blood is not leaving, and then the fluid starts to pool in the tissues, causing edema. And if the stroke volume is really, really compensated or not compensated, you can see systemic shock. So mitral regurgitation is backflow from the ventricles because we do not close this appropriately. Okay. The more common disorder that you will see because of the way scar tissue works is mitral valve stenosis. Well, I don't want to say the more common, but it is the most common valvular disorder that is reported in the literature. So anyways, mitral stenosis. Back to what I was saying. A stenotic mitral valve is when there is not a good opening between the atria and the ventricle on the left side. So instead of having this nice open passageway for blood to flow unimpeded from the left atrium to the left ventricle, where, remember, the left atrium would only have to pump a little bit to add a little bit, 1/3 extra blood. Instead, we have this tiny opening or some sort of narrowed opening, which means instead of having an easy job of just pumping the blood that should just flow, the atria is going to have to work really, really hard and contract strongly to move the blood then into the ventricles. This is most common. Again, it is generally the result of these rheumatic fevers, so this reaction to strep type bacteria, or general bacterial endocarditis, which is more, it can be strep related too, or staph related. So that is usually referring to bacteria that comes from the mouth. So if you think about dental surgeries, things of that nature, those can go and cause heart difficulties. So when those types of infections occur, again, when there's damage to the valves, there's this overactivation of this tissue factor system. During healing, the orifice gets really small because of the fibrous coating on it. Those heartstrings we talked about, the chordae tendidae, we see them right here, they're also fibrous. So not only will there be scar tissue on the valve, it'll also congregate on the chordae tendidae itself. So they become shortened and fuse, which make it even more difficult for this to function appropriately. So the main point here is there's decreased flow from the left atria to the left ventricle. And instead of, like in regurgitation, we saw both the atria and ventricles got larger. In this case, what's overworking and has to pump really hard to move the blood is the left atrium. So that will be the area that is hypertrophic. Okay, then there's aortic valve regurgitation. Again, just a little bit of anatomy review. Here's the aortic valve. It separates the aorta from the ventricle. So when the ventricle beats on the left side, we want the blood to go out to the body. So during contraction, that's when the AV valves are shut. So we already went through that. Now, when there's relaxation of the heart, that's when the backflow of the blood causes the snapping shut of the semilunar valves. That's your second heart sound. And that prevents blood from backflowing. In the case that the aortic valve has regurgitation, which you can see, same thing, rheumatic fever, endocarditis, syphilis infections. You can see this from high blood pressure, where we just have a really, really overworking heart causing abnormalities to the system. High afterload pressure, backing up and damaging the valve, Marfan syndrome, so stretching out of connective tissue, or atherosclerosis, where the hardening of the arteries causes abnormalities to the wall. In this, we get the reflux of blood from the aorta down to the left ventricle during relaxation. That means every time the left ventricle beats, it's going to have extra reflux blood in it. So it's going to have to now beat really, really hard and really long to move that blood up. It's doing major sets right now. Its gains are intense. It becomes very hypertrophic. It looks globular, like a globe on that side. And because of the way the body works, when this happens, less blood can come in then from the lungs. So then the pressures are going to build up in the lungs, which then back up to the right heart. So that will eventually lead to the right heart having some sort of failure. And then finally, we have aortic valve stenosis. So that is when the left ventricle has to beat blood through a really high afterload pressure. So a tiny little valve here. I want you to notice, this is just a drawing, but look how big this is. This is a huge wall that you can see in aortic valve stenosis. Most common causes, rheumatic heart, these strep type infections, bacteria, immune responses. In some individuals, this can be congenital. Or in that picture we saw earlier, in really progressed cardiomyopathy and hypertension and atherosclerosis, you can see severe calcification occurring on this damaged area. In this case, the left ventricle is what's obstructed. It cannot pump blood up through the aorta. The left ventricle gets really, really big. The heart rate is going to change primarily by increasing the length and the strength of the contractions. Your heart can only do that for so long. It just is not going to live that way for that long. The pressures are going to go up in the left atrium because it's waiting to send the blood on down through, and it can't, so those pressures go up. So you're going to build up pressure to the lungs, which are waiting to give blood to the atria, and that's going to build up pressure to the right heart, and then so on and so forth. Left heart failure will always cause right heart failure eventually. There's only two sides of the heart. If one fails, the other one will result. Okay. Just a couple things. I've mentioned rheumatic heart disease. So it is a complication of these group A beta hemolytic streptococcal infections. When that occurs, you get these antibody complexes forming. They hang out on tissue. They cause a lot of inflammation. And when they're there, they cause these endocardial issues that we just looked at. It can also migrate to the myocardium, so causing inflammation of the myocardium called myocarditis, and the pathologic lesion for that are called Askoff bodies. Regardless, just know that this is one of the most common types of reasons you would see valvular damage, and you can prevent these strep type infections by treating them with an antibiotic. So just strep throat, knowing how to recognize it and what antibiotics are most effective to treat it are so important in preventing valvular disease. Okay, and then the final thing I just want to talk about, since we mentioned it, is mitral valve prolapse. Mitral valve prolapse is when, you can read this here, I want to show it to you over here. Mitral valve prolapse is when, instead of the two leaflets of the mitral valve, remember bicuspid, there should be two cusps, they should snap shut really nicely. Instead, in mitral valve prolapse, they fit together like this. So instead of having a nice tight snap, they do their best, but when something is prolapse, it means it maintains its general connection, like these are still a part of the heart, but now they've moved out of their anatomical location. The way that you'll know right away, like if you're looking at association for things like words or for sounds, there is a diagnostic criteria for mitral valve prolapse. And not only will you see exercise intolerance, but the diagnostic criteria is lub-dub, lub-click-dub. That on auscultation, when you use your stethoscope, you should hear lub-dub. If you hear lub-dub, that's a sign of mitral valve prolapse. As we mentioned, it's more common for blood clots to form in cases like this. And it's, ooh, my arrow just got really big. That was fun. I did it again. It's also more common for this to pick up bacteria or the immune complexes that form in relation to that. So giving prophylactic bacteria before dental procedures, before surgical procedures to prevent the damage through scar tissue development in those who suffer with mitral valve prolapse is recommended. Okay, and whoa. And then the very last thing I mentioned with valvular damage, it could be due to infective endocarditis. This is something essentially different than these group A strep types of species. So this could be a fungal infection, this could be some other type of bacterium, but instead of seeing things like Askoff bodies, you'll see these little vegetations. And what I told you earlier is that, like, looking at those clinical pictures, you saw those little red spots on them, right? So that means there was some sort of bacterial infection, and those are resulting vegetations from it. So infective endocarditis can happen whenever there is a bacterial infection of the valve. This can either be acute or subacute. With the heart, most things that are acute are much worse. So if there's an acute infection that develops, let's say that somebody had non-sterile surgery, and now that bacteria has gained entry to the heart, or maybe they have an E. coli infection that went bloodborne and it's antibiotic resistant. If that's the case, that will cause an infection and then the development of a blood clot. And if that blood clot leaves, that's what we call embolization, or if it's colonized by a different type of bacteria, death within 2 weeks is common. So if you don't treat it, or it breaks off and it moves. And people are very sick with this. They have abnormal heart murmurs, so you can hear blood moving abnormally through the heart. Remember, murmur just means turbulent flow. Very high fever, shaking, chills. They're very sick. Then there's subacute. That develops over 3 to 6 months. There's a fever, anemic symptoms. Malaise means a general feeling of being unwell and just debilitated, like you can't do anything. Everything feels impossible. You can see this when there was already a pre-existing heart condition and it allowed bacteria or another foreign body to propagate there, or if there was surgery to the region and now there's the entry of a bacterium into the body that shouldn't have been there. But because it's in the blood, it'll eventually make its way to the heart. And heart valves are a really nice big place to put stuff, unfortunately. So this is pretty dangerous. You saw the lesions. The lesions are pathologic lesions, meaning that they cause death and they were taken from the body for pathology. So just know that they're very, very serious. So here's some more lesions. Again, I want you to get used to looking at these so that when I describe them with words, you know what I'm talking about. So here's bacterial endocarditis on the mitral valve. So you see these vegetations there. Yes, you see your fused shortened chordae tendineae, and then you see the resulting scar tissue. Same thing here. Here's very severe. This is from a staph type bacteria. So normal mitral valve with leaflet destruction and perforation, meaning there was a hole essentially punched in it. So we see these vegetations, we see the damage then to the chordae tendineae. Everything else looks pretty good, right? But remember, this yellow stuff, that's our fibrous tissue. So that's your scar tissue, and that's what you don't want. So that's what these things look like. Yeah, these staph, you can get staph infections from surgery. They're pretty common. They're all over the place, unfortunately. You also have a lot of that bacteria in the mouth, which is why you want to be careful before dental procedures. And when people have already abnormalities to their valve, including mitral valve prolapse, which normally wouldn't cause very many symptoms besides difficulty exercising and a weird heart sound, they're more at risk to developing blood clots and resulting infections there. Okay, so those were your valve issues. I hope you enjoyed looking at these gross pictures. I have plenty more where that came from.